I'd like to welcome everybody to this COVID-19 special seminar, the third in a series that MIDAS is putting up this summer. So today we are privileged to have John Zelner speaking to us. John got his PhD in sociology and public policy from the University of Michigan in 2011. And then he went away, spent some time at Princeton and Harvard and Yale and Columbia, and came back to Michigan just 3 years ago, roughly, and is now on the faculty in the Department of Epidemiology in the School of Public Health. John Zelner is a social epidemiologist whose focus is understanding the joint social and biological drivers of infectious disease, which is particularly apt in the times of COVID-19 and social distancing. And so I'm eager to hear John talk about the current outbreak and what to expect after all the interventions, the major interventions that we have had. John?
Yeah, great. Thank you for the introduction. And so, if you have questions, I'm going along, just pop them in the Q&A and I'll be happy to talk about them. So can everybody see my screen right now? Can you see the slides? Okay, just making sure. The friendly little outline disappeared. So the title of this talk, right, is "The Outbreak Ended, but Did the Interventions Do Anything?" And that title, so this is actually a project that I've been working on in one way, shape, or form for a little while now. And I didn't expect that it would necessarily become as relevant as it has right now. So before I kind of get into the meat of the talk, I did want to kind of plug something, but also, give you some directions to some resources that may be of interest. So the talk that I'm going to give right now is not strictly about or only about COVID, but my group is doing a lot of work looking at the spatial distribution of COVID-19 in Michigan, and particularly looking at spatial heterogeneity. And we just received some of the MIDAS PODS funding to continue doing this work, which we're very thankful and excited to kind of use to push this forward. So I can pop the link into the chat or the Q&A, or maybe James can do that. So that you can kind of look at this as we go along, because I think it's helpful to put in a little bit of context while we're talking about what I'll be talking about here, which is just a little bit more abstract in some ways. Okay. So, institutional and high contact environments have really been key sites of COVID-19 infection and mortality. I think, one of the earliest examples of this from the ongoing pandemic was the Diamond Princess cruise ship, which had, just a huge number of cases and a large number of deaths during, the very earliest phases of the pandemic. So, this is, cruise ships are kind of well known for being ideal environments for infectious disease transmission. Historically, we would think of them particularly as being hotbeds of things like noroviruses, which is actually where I started my career as an infectious disease modeler. But, you have high contact within, this environment where there's lots of people, a lot of density, lots of shared surfaces, lots of opportunities for transmission to occur. And that's exactly what we saw. So these outbreaks are really important in their own right, but I think they also become very important because they become sort of like little natural experiments that we may want to use to say something about, did quarantining, did social distancing work, did disinfection work? And so when we look at outbreaks in this kind of context where we're sort of putting a box around them and saying, this is a place, a context in which transmission occurred, there was some intervention, did it do anything? The talk today is really going to focus on the issues around making those kind of inferences. And I think that the ideas scale up to the population level, but we're really going to be thinking at this level of infection is introduced into a population, whether it's a nursing home, it's a cruise ship, it's a community, it's a school, but something that's kind of relatively small, and we're looking at change over time, and we're trying to say something about whether interventions or behavior change actually cause the end of an outbreak. So, one thing that's really important to remember is that individuals in these kind of institutional environments are often among the most socially or medically vulnerable people. So attention to them is not only important from a scientific perspective, but it's really important for thinking about issues of health equity. And so, we want to learn how to address these outbreaks, not only because we can learn things that might help us in the general population, but because the folks who are often on the receiving end of transmission in these contexts are most often the worst off. Similarly, people who are at high risk of infection exposure, for example, in these nursing home outbreaks where there's been just a massive burden of morbidity and mortality. I think in Michigan, a third of COVID-19 deaths have occurred in nursing facilities or long-term care facilities. These are folks who have, extremely high risks of severe outcomes and death. And so that's really important, both because of its epidemiologic and, medical implications for those people and for the people around them. But it also means that we have to think really carefully about taking inferences from a particular context where you have a group of people who are particularly susceptible, at particularly high risk of severe disease and death, and extrapolating that out to the general population. So my argument here isn't that it can't be done, but that we really need to be thinking about what's in the data we're looking at so that we can adjust appropriately to say something about the general population. Okay. So, if I'm trying to understand what to do in the context of an emerging infectious disease, like I said, these intervention effects that we get from outbreak data are really critical, right? So do we practice case isolation? Do we ask people to wear masks? Do we engage in significant environmental decontamination efforts? Down the line, how do we deploy vaccinations? And our needs to estimate these effects really are the greatest when our data are limited, right? So it's a real bind because we don't have the luxury of time right now or during any kind of emerging infection. If we go back to the Ebola crisis in 2014 in West Africa and Zika, right? We want to do online learning to understand what's going on, but that's exactly the moment when we have the least information. And the other part of this that I'm going to really hone in on today is how does heterogeneity or what we might call superspreading, although I want to be careful with that term, that's characteristic of many emerging infections like COVID-19 impact our efforts to make these measurements, right? So some individuals may be particularly infectious, and that may be because they excrete a lot of virus or they have a lot of contact, and that may influence dynamics, particularly in these kind of small, closed populations, in ways that are hard to predict and that may make it even more difficult to say what's going on. And then finally, how do we know if the effects that we identify in one place or another can be generalized to another? Okay. So this is a little bit of a cartoon, but what you're seeing here is just the idea that modeling intervention effects in these kinds of scenarios using before and after comparisons is tempting, and it may often be the only thing we have available, but it's totally fraught with danger, right? So, this is just a sort of a silly example of that, where we see incidence rising in a very classic looking SIR or SEIR style intervention. And as we're climbing up that hill of incidence, we say, uh-oh, something's going on, time to quarantine, time to wash hands. And then, there's a little bit of a delay, maybe while the last set of cases trickles out, and then we see incidence going down, and we congratulate ourselves for having done a very good job, right? But anybody who's paying attention would look at this and say, well, maybe you just ran out of people to infect and the thing burnt itself out, right? But it's kind of a well-worn trope in infection control that people often kind of ride the coattails of the epidemic to glory, right? So that you kind of slide down the backside of the incidence, and you can say, well, my intervention, which was triggered by hitting this peak, which may have been actually the causal effect in the risk going down, either because you run out of susceptibles or because it triggers some kind of disease-limiting behavior, or just luck of the draw causes the thing to die out. So it's really easy to get what we would call confounding by indication, which essentially you have a diagnosis or you detect an outbreak, and it's that detection is confounded with the natural extinction of the event. Okay, so I'm just going to pause here and make sure there's no kind of clarifying questions. Okay, great. Okay, so to do a better job of this, right, we can't just look, or we can't just assume that the universe of outbreaks that we observe is purely representative of the universe of outbreaks on the whole. So, you know, a lot of what I'm talking about today is really laying the groundwork for thinking about how we can account for the outbreaks that we didn't observe. Right. And so when I say outbreaks in this case, I'm really talking again about some kind of transmission event where we're putting a box around transmission, right? So you have a nursing home, a school, a long-term care facility, a cruise ship where infection comes from outside, there's localized transmission, and we really kind of focus on what's going on here, right? But one thing that's really important, you know, if we look at these kind of connected peaks over here, these individual outbreaks, which are often how we address infectious diseases from a practical perspective in sort of an on-the-ground public health kind of way, particularly when we don't have population-level interventions like vaccination, are really these kind of interconnected stochastic effects. So when I'm thinking about one outbreak, the world of the epidemic is really composed of a lot of little outbreaks that are all chained together, and it's really a question of how we look at them. Okay, so you know, when are our observed outbreaks likely to be systematically different than those that we don't observe and don't analyze? So certainly in cases where disease severity or case fatality is high, such as these nursing home outbreaks, we're just more likely to pay attention to them because the burden is just so much more clear. Maybe we're doing contact tracing or we're using pathogen genomic data, and it shows us that cases are linked, and that causes us to go back and conduct some kind of a study to estimate transmission rates, to understand, you know, what the heck's going on here. So that's another kind of observation effect that might kind of play into what things get analyzed and what don't. And then if you have an unusually large attack rate, like in the Cook County Jail and in Rikers Island in New York, combined with high rates of severity, high rates of fatality, you may be more likely to observe those places, right? So again, this isn't an argument against doing those kinds of analyses, but we have to really kind of ask ourselves, when we look at an outbreak, what are we looking at and what's the sampling frame that it's coming out of? So, you know, the big sort of theoretical argument here is that by just observing these particularly large, particularly, you know, important or anomalous outbreaks, we potentially increase the likelihood of confusing regression towards the mean with effective intervention, right? So we've thought a lot recently about R0. That's certainly a quantity that's been in the news a lot, or R of T, right? So thinking about the way that the average number of secondary cases changes over time, possibly as a function of intervention or just other unobserved factors, right? So if we say little r sub 1 or sub I is the ith case in terms of their order of becoming symptomatic, let's say we start with an index case that has an R1 of some value C, where C is big enough to, you know, start an outbreak. So, you know, just knowing what we know about regression towards the mean, if we start with an R1 that's greater than R0, which is the average infectiousness, we should expect that the next value, the second person, is going to be smaller than R1. So this is just independent random sampling. And because we've drawn an extreme value, we're getting, you know, we're more likely to see that kind of come towards the mean. So in other words, if I start out my outbreak with a highly infectious person, so some kind of super spreader or maybe a group of cases, the subsequent ones are likely to be closer to R naught. And I think you can start to see the picture of how, we may end up then in the situation where we, get what looks like a positive intervention effect when in fact nothing is actually going on. Right. And so again, this idea of a super spreader often brings to mind a, one individual, sort of a, typhoid Mary moving around, infecting lots and lots of people. But you can also think of a super spreader or a, particularly influential spreader as being a healthcare worker moving between patients in a long-term care facility, where that person just has many more opportunities for exposure and for transmission than patients who are often, kind of in one place or having a limited area of exposure, right? So I prefer to think about this in terms of heterogeneity and variation rather than super spreaders, both because super spreaders implies an extremity that's not necessary to have, bad outcomes, and it also is kind of unintentionally stigmatizing. So, the other thing we know is if R naught or the effective R, so R naught is the average number of secondary cases an individual would generate in a totally susceptible population. Often we talk in outbreaks about effective R, which is just the number of realized cases that somebody generates, not worrying about how much immunity there is in the population. Although in a pandemic, these kind of start to bleed together a little bit. So if R naught is near or below that critical threshold of 1, your outbreak is likely to end via stochastic extinction no matter what, right? But depending on how you observe the trajectory of the epidemic, you may not capture the fact that the true R naught, the true mean is close to 1. Okay. So certainly I wasn't the first person to think about this. So this is some work done by Ben Cooper a number of years ago, looking at the impact of observation biases on the estimates of infection control measures for things like MRSA, so drug-resistant Staph aureus infections that particularly at the time were very common in healthcare facilities. At this point, there's certainly a lot of healthcare-associated MRSA, but it's also moved on to be a significant community pathogen as well. But in the early days, there was a lot of concern about, hospital-acquired MRSA and hospital-based MRSA transmission. And so basically all they did here was to say, okay, let's look at different values of R naught. So up on top, you have an R naught of 2, and let's run this stochastic model and wait for a period where we have a lot of cases just by chance, right? So there's just stochastic fluctuations. We get into a period of, a modeled set of months in which we have more than expected cases. And then we say, okay, at the end of this year, we're going to start an aggressive infection control program. And what this is showing you is for whatever value of R naught you have, it's very easy to get a decline in the estimated value of that R of T, right, as a function of just stochastic extinction of the epidemic, right? So, and this is assuming very minimal variation between individuals. So this is just kind of a vanilla model where people have exponentially distributed infectious periods, and those are giving you some variation, but not a ton, and certainly not on the order that we often see in real world infectious disease outbreaks. So, we kind of already know that we can get this kind of confounding just by selecting on looking at the largest outbreaks. And so the other way we can put this is that the universe of modeled outbreaks is really just the tip of the iceberg. And if anything, this image here is probably an underestimate, right? Like I would say we're probably seeing, depending on the pathogen, we're seeing maybe this much. Maybe for something like COVID, where there's a lot of intention and a lot of severity right now, we're seeing more. But if we think about other pathogens like noroviruses, which are a little bit, are unpleasant, but kind of more run of the mill, we're probably seeing that, if not that. So, the question to me is how much does super spreading increase this risk and when, or how much does heterogeneity increase this risk and when? And this is just a nice figure from a paper by Jamie Lloyd Smith from 2005, looking at the relationship between the dispersion parameter of a gamma distribution. So basically, as we go towards the right here, where the variance of infectiousness is decreasing, and how that plays out for different pathogens. So up here, we have our old friend SARS coronavirus 1, which was the pathogen that was implicated in the 2003 SARS pandemic that didn't play out to be as much of a global event as this one is. But you can see that the dispersion parameter for that was about 0.01, right? So a 1 is that normal, I'll put in quotes, exponential variation that previous model I showed you assumes, and that most SIR models kind of either implicitly or explicitly assumes. But going back to this earlier epidemic, we see that there's considerably more variability, so that SARS-CoV-1 transmission appeared to be significantly over dispersed relative to the way we often model it, and it's not entirely clear where things are headed with this particular pathogen, but it wouldn't be surprising if it was down here or at least somewhere between here and here, right? So more variability than we're usually used to thinking about. And we know that when we increase heterogeneity, we get more explosive outbreaks, right? So that heterogeneity can be a function of individual infectiousness, individual variation in the amount of virus that you're shedding, individual variation in the amount of contact you're having, and it can also be a function of the population that you're in, right? So right now we're in these relatively early phases where there's very little acquired immunity to this infection in most populations, but as we go along, more and more people ostensibly will have some kind of acquired immunity, and then you'll show up, infection will show up in a nursing home, a hospital, a school, and that will induce stochastic variation in terms of how many susceptible people are there to infect, and how do they interact with the individuals. So this is, okay, so there's a question here which just is asking if this is analogous to the recent reanalysis of the Camden Hotspot or Super Users Initiative. So that's actually something I don't know about. So if you want to send me more information on that, I can give you a little bit more background. Thank you. So let's see. So I just want to pause for 1 second again, make sure everybody is following along, and often these things can be a little bit, speaking into the void. And historically, I'm used to at least a room full of like partially awake undergraduates. So please do let me know if you're getting lost or something occurs to you. Okay. So here I want to provide a bit of a motivating example, which is not SARS related, but I think kind of does a nice job of showing us how these dynamics can play out in a real world situation. So this is, we're going from the solemn to the slightly ridiculous here. So this is a large and quite gross outbreak. This is from a paper that was published in 2009 about a very large norovirus outbreak at a scout camp in the Netherlands. So there were about 3,000 campers at this camp that gathered over a 16-day period, and over that time, 300 of the 3,000 campers became ill. So on day 3 of the outbreak, these intensive hand washing interventions were applied. And they used a branching process model, so just a transmission model that suggested the interventions successfully lowered the transmission rate. So they're estimating that RFT, how much infectiousness is changing over each day of the outbreak, and they argued that these interventions successfully lowered the transmission rate and contributed to the end of the outbreak. And so this is, I think, an interesting paper, and it's the one that really got me thinking about these ideas, right? So these are the data. So it was a scout jamboree where you had these 3,000 campers who were divided among 7 different camps. And you can see this is the first day, and this is where you're in trouble because a couple kids showed up and they were already sick. And so over the next several days, you had this ramp up in active infections, but it didn't really start taking off until the 3rd day. And this again relates to the latent period of norovirus infections. So, if you get exposed to norovirus and you are infected, it can take anywhere from 12 to 36 hours to develop symptoms, and you see there's this delay sort of popping out, right? And so this is one of the big motivations for using transmission models to kind of deconvolve infectious disease data, because we need to account for those delays. So you see here, they implement these hygiene measures, and then the thing just kind of keeps bumping along, then it ends, and then some cases kind of continue to show up among the campers who've gone home in the days after. So they estimate the reproduction number over time, and so this is a figure that probably, for those of you who don't work in infectious disease or infectious disease modeling, you might not have really seen anything like this prior to January, February, March. And now this idea of this like reproductive number changing over time has kind of entered the popular consciousness in a way that I never anticipated and hoped never would. So what you see here is this estimate of the average infectiousness of cases that are becoming ill on each day of the outbreak. And so you can see what they did here was they said, okay, here's the implementation of these hygiene measures. Let's imagine that, we were at this level before the hygiene intervention started, and whether or not it continued to go, because it continued to go down, maybe the interventions were effective, right? So to me, like, it's hard not to look at this and say, well, maybe, but there's quite a lot of decrease happening ahead of time. And how do we know that we're not just seeing regression to the mean over here anyway, just in that way that I described earlier on, right? And so for noroviruses, it's quite easy to imagine how these like super spreading events occur, because it's a disease that's characterized by vomiting, and usually sort of sudden onset projectile vomiting. So if you're that unlucky camper who gets sick, in the dining hall, that's an opportunity to expose a lot of people, right? So again, it may not just be some quality of view, but it could be this kind of intersection of, where you are, how many people are there, and some kind of disease-related event. So what other things could explain the decline here? So maybe we ran out of susceptibles, maybe we had contact heterogeneity, maybe there's some between individual variation and infectiousness. So again, why could this heterogeneity be problematic for making inferences about other contexts? So zooming back out to our question about COVID-19, if I study the Diamond Princess outbreak, what are the things that I can hope to learn from that? Or if I focus in on the Life Care Nursing Home in Kirkland, Washington. So obviously not all outbreaks are equal in terms of their magnitude or in the severity of their outcomes. If we think about noroviruses, most norovirus outbreaks never pique the interest of public health authorities or modelers. So the things we analyze are probably the most extreme ones. Certainly for COVID, we can imagine that we're more on alert for these kinds of things than we would be otherwise. But the high rates of asymptomatic transmission, the fact that some people have very non-specific symptoms, and going forward, as we have more co-circulation with other respiratory viruses like RSV and influenza, particularly going into the fall flu season, it may be harder and harder to pick out COVID infections from other of what we might think of as more garden variety illnesses. So even this thing that we think of as being very severe and very acute, and it often is, may be getting more lost in the wash than we even appreciate right now. So what I want to show you right now is, how our inferences can go wrong when we only focus in on these big severe outbreaks and where interventions have occurred, and we're trying to tell you whether or not they did anything, right? So going back to the title of the talk, which is, did the interventions do anything? And how easy then is it to attribute intervention effects to what's really regression towards the mean? Okay. Oh, I see there is a question. So let me just take a quick pause here. Oh, great. So just a little more information on the Finkelstein paper. Okay. So what I did here was I put together a little design analysis, right? So basically, one of the wonderful things about infectious disease transmission models is that we can not only fit them to data or use them to kind of simulate out the world as we imagine that it might be, but they provide a pretty nice testing ground for conducting all kinds of counterfactual experiments that we can then use to inform real-world data collection activities, right? So here I'm not trying to claim that this is a particularly accurate model of anything in terms of its time dynamics, but more that it kind of puts a set of bounds on what we could expect to find in different situations and what we should be worried about, say, when we do find an intervention effect in our nursing home outbreak or a large norovirus outbreak in a scout camp. So we're assuming a closed population of about 1,000 individuals. We introduce a single infectious case, right? So this could be a small community, a school, really any kind of homogeneously mixing population. And here we're assuming no protective immunity. So what I did was simulated different outbreaks with different average infectiousnesses, right? So that R naught value and different levels of between individual heterogeneity. So the parameter K. So as K goes down to 0, the variance goes towards infinity. As K goes towards infinity, the variance goes down to 0. And then what I did was just select outbreaks that had a final size greater than some outbreak threshold, say of 10. Right, so here I was thinking about noroviruses, right? So when I first did this, so 10 norovirus outbreaks tells me something's going on. I might, in this case, one or two symptomatic COVID cases might actually be about right, but you have to remember that there's probably a very high ratio of symptomatics to asymptomatics. So, even this kind of probably fits reasonably well for COVID in the context of like a nursing home. And then we'll estimate the value of R naught before and after the intervention threshold, so that threshold C is reached. But in this case, I'm not going to apply any intervention. So I'm going to pretend that I did something, and then I'm going to look and see whether the average before or after changed. And here I'm focusing on estimating R naught, not effective R. So this is the infection potential, not the realized infection, which goes down as the number of susceptibles goes down, right? So as there's fewer people to infect, your infectiousness to the remaining, well, the expected number of secondary infections necessarily goes down. But here I'm just looking at infection potential, right? Like how much force of infection am I exerting? And then for each combination of R naught and K, I'm going to calculate the proportion of simulations where that R post, so after my dummy intervention, is below 1 and it was above 1 before the intervention. So we're only looking at that subset where the intervention could be attributed as the cause, even though it was likely regression towards the mean. So, concretely, what do the parameters obtained from doing something like this tell us about, the general population of outbreaks? What is the population of outbreaks? And, how does this observation bias, where we focus on the most sort of large or meaningful outbreaks, or perceived to be meaningful outbreaks, and the between individual heterogeneity, impact the meaningfulness of the conclusions that we draw from these kinds of data? So again, so this is what I did, simulate, and then we're going to calculate the proportion of simulations where this occurred. So what you see in this figure is the average pre-intervention infectiousness of cases as a function of, this should say R naught, so of the average infectiousness and of the dispersion parameter. So apologies for the axes being a little bit sloppy, but essentially what you see here is that when we have that kind of dispersion in that sort of 0.1, 0.01 to 0.1 range, which again, we associate with the kind of old SARS-CoV-1 and other pathogens like measles and noroviruses, that even if your starting R is low and below 1, right? So maybe it's the actual potential in that setting is less than 1, so we should expect that the outbreak will just burn itself out. The pre-intervention R could be really quite high. Right. And so remember, one thing we know from earlier modeling work is that more heterogeneity leads to more explosive outbreaks. And, intuitively, it makes a certain amount of sense, right? Because if the large majority of the cases have an individual R less than 1, to really kick this thing off, you need to have those first cases out of the gate really pack a punch. And that's what you're seeing here. So as the heterogeneity goes down, the spread on this decreases, but we're still well above 1 in most scenarios. So what this is showing you is the proportion of outbreaks that cross that critical threshold, right? So they go from R pre above 1 to R post below 1 without intervention as a function of the R naught and of the heterogeneity. So, down here, it shouldn't necessarily be surprising that for ones where the R naught is less than 1 or in the neighborhood of 1, there's quite a lot of them that are fizzling out on their own. But you can see that it's like 90% of these are burning out. And, so if I have an outbreak where I estimate some positive intervention effect and the true R is actually, 0.9 or just around 1, the chance that I've basically just completely confounded it with observation biases is quite high. Okay, so this question is your simulation of all potential concatenations of events essentially an exercise in randomization inference? That's a good question. I think it would be, so I guess, are you sort of talking about in terms of, like a non-parametric sort of like permutation testing approach? I think you could say that, but, what we're looking at here is kind of all possible combinations of the parameters. But in reality, we usually have some kind of prior on what that should look like. But I'm happy to sort of talk a little bit more about that at the end. Okay. So as we increase R naught, there's a higher likelihood that you have the intervention and as a function of susceptible depletion. But over here, what we're seeing, is still that, in this range where where R naught is kind of in that zone of 1, or effective R is in that zone of 1, things get pretty hairy. So, in terms of thinking about the relevance of this for thinking about COVID, right, many of the estimates of the sort of population level R naught of COVID are something like up here, right, in like 2.9 or 3. So as R naught goes up, this becomes less and less of a concern. So when we're thinking about, population level dynamics, at the beginning of a pandemic with a highly infectious pathogen, this is maybe not in always the most relevant thing. But what about when we're in a nursing home or a jail where there has been a lot of transmission, there's been some uptick in acquired immunity, but cases are continually being imported from the community, right? And then, so we have a flare up in the facility, and then we try to intervene and we see that it went down, and we tell ourselves, you know what, we did a good job because we were able to, contain the outbreak. And it may well be the case that we've just been riding on the back of kind of random noise. And that's going to become more and more of an issue as we kind of move into the second phase of this management of this infection as a kind of chronic thing that's bumping around in the population, and potentially as a kind of seasonal irritant. So yeah, so I'll pause there. I mean, so this is, kind of a theoretical, kind of high level look at the ways in which it's very easy to get what look like strong intervention effects when in fact nothing has occurred. And, I'm happy to talk a little bit about the ways in which, we can possibly move this from just a kind of like theoretical sort of design analysis into something that we might actually use in real life. But that's what I had prepared. So I'll pause here and just see if there are any questions. Okay. So since in my sort of remaining time here, if there aren't any questions coming in at this second, I'll point you back to the work that we've been doing looking at the state level, right? So if we want to think about the relationships between these two things. So, so this is a map that some folks in my research group and I have put together, along with Paul Dahlmatter, who's at UNC in the geography department. And so what we're looking at here, if you click on that, you can see the rates per 100,000 in these hexagonal cells, which are about 10 or 20 kilometers wide in this instance. And if you play this, you can see the case rates, the cumulative case rates increasing over time, right? So if we go to the end here, when we start seeing outbreaks up in this part of the state, maybe that will end up might end up not being as hard hit as Southeast Michigan, we have to think about how the amount of acquired immunity in places that are harder hit might induce more stochasticity, right? Might give us a noisier signal of transmission and of intervention effects than in places that are starting out relatively untouched, right? So in terms of thinking about the practical applications, we have to think about how spatial heterogeneity and that community exposure might lead to heterogeneity, not only in the risks going forward, but in our ability to A, intervene effectively, and B, know that we actually did something. Okay, so here's another question which says, what would be the way to measure whether we miss the opportunity to stop the spread? So this is a great question. In that case, what would your model say? Is any policy better than none to get some marginal benefit in R0 reduction? Okay, so there's a lot in here, so let me go through. So, one of the things that's really tricky is if we knew some like abstract R0, if we knew the truth such as it is, then we might be able to benchmark everything against it. But I think one thing we've learned through the context of this, through the course of this pandemic so far, is that R0 or these transmission parameters are not just abstract parameters relating to the properties of a given virus, right? They're this complex interaction of the environment and the individual's biology and comorbidities and their contact patterns. So it is hard to kind of abstract away from one context to another. So I think the way to measure whether we miss the opportunity to stop the spread, it's a hard question. I think if there's just been a lot of incidents, right, you can tell how many cases you could have potentially averted. But the flip side of that is, there's always something you could do. So certainly none of this is an argument against intervention. But I agree, having more information on where we are, so that's either through serology, so through testing to see what, people's antibody profiles look like, and active surveillance of disease could tell us where we are and could give us, a better way of bounding our expectations about what we can accomplish. And yeah, I think, is any policy better than none? Certainly, marginal benefits, marginal reductions in R0 or in infectiousness mean fewer people getting infected, mean fewer deaths, mean potentially more time to develop a vaccine or other effective therapies, right? So often we get blinkered into this idea that the only thing that's useful is an intervention that is so effective that it crushes the infection. And more often than not, we don't have those things, right? So the flu vaccine is a good example of that. The flu vaccine saves a lot of lives. It's likely prevents a lot of unnecessary morbidity and mortality, but it's not a slam dunk, right? Similarly, there's a tuberculosis vaccine called the BCG vaccine, which some folks may have had, which again does not have huge amounts of protection against transmission, but it does protect against some of the more severe outcomes associated with TB infection. So, public health is really a place where we traffic mostly in marginal interventions, and what we hope to do is pile one marginal intervention on top of another to decrease risk to the point where we have things under control. And often we get stuck into this way of thinking it's like we need an amazing, perfect vaccine to shut everything down, when the truth is really it's this combination of like wearing masks, washing your hands, getting better antivirals coming out of the pipeline, thinking about contact patterns in institutional facilities, right? So it's all of those things. And so we shouldn't get too discouraged because any one thing doesn't work. It really is very much a cumulative exercise. So I think that's a very important point. Cool. So I think that takes me relatively close to the end here. I don't know if anybody has additional questions or comments or thoughts. How do you estimate the effect size for interventions? Okay, so that is a great question. So, and unfortunately, I don't. So I guess this ends up being a sort of a philosophical question in certain ways, right? So it's this kind of you have to construct this counterfactual where you could understand what was going to happen but for the intervention. So if we go back to the slides, which I've conveniently hidden from myself, thank you. There we go. Right, so if we go back to this example from this outbreak, here we have this kind of decline, right? And you can see the spline that they fit, and they're kind of making this, what I think is arguably a somewhat questionable assumption that, well, it was declining, and then here it's like, we're just gonna assume it had been flattening out. And so, we'll say anything below that is attributable to the intervention. So that's shaky. But at the same time, I think you could imagine, well, okay, let's say we do have this selection bias, right? Like that's not inherently a problem. It's not inherently a bad thing. But if we could somehow parameterize this process of decay, then we might be able to say, well, here's what we might expect to see, or maybe we can do some sort of sensitivity analysis to say, here are all the ways we can imagine this playing out if there was no intervention effect, right? So you could just have that process of regression towards the mean, just coming from just that simple random sampling, where we start out with an anomalous individual or anomalous case, and then we estimate a fixed effect that says, well, what's the average change before and after? So we account for the fact that there may be regression towards the mean, and then we look at any changes beyond that, right? That ends up being a very stringent test, right? And so that's the thing that makes this challenging is we shouldn't necessarily expect to see a clean break here, right? So, if we could go to that nice place of like causal inference with some kind of regression discontinuity, like that would be awesome. But we know that there's probably going to be some time for an intervention to kind of take, right? So a hand washing intervention might take time to ramp up. Or if we think about mask wearing, right? This is a social process as much as it is a sort of public health or epidemiologic one. And so, the dynamics of these things end up being kind of complex as well. So where you can, if you can say, if you have enough time to say, is the average, here, greater than it is here, adjusting for this other stochastic process, then maybe you could get somewhere. But it does become quite tricky otherwise. Cool. So certainly, we have time for any additional questions if anybody has them. And if not, I'm happy to yield the floor there. And certainly, do get in touch if you have questions after the fact. And you can get in touch with me at this address, or check out my website, or check out our website at covidmapping.org.
All right. I guess that brings us to the close of today's seminar. Let's give John a round of applause. Thank you very much, John, for a fantastic talk. Really appreciate that.
Yeah, thank you.
Want to tell people that our next seminar in this series is on Wednesday next week, also at 1 o'clock. And this will be by Karandeep Singh from the medical school. So look forward to seeing all of you there. Thank you.
Great, thank you.